start to watch a tracheostomy insertion at the bedside, and then the patient coded. So we got to see even more action than what we really wanted, but they can do them at the bedside also. Nasotracheal tubes, there is a little box in your notes. I don't have the page number right now, but there is a little box. It is on page 1374. It's a comparison of endotracheal tubes and tracheostomy tubes. But I'm going to give you just a little rundown on the advantages of it. Supposedly it's more comfortable. I don't believe that. Most people that have nasogastric tubes complain the whole time. It is more easily secured because you're not dealing with the mouth. They are unable to bite down on it. I believe that to be true. And you can do better oral care because there's nothing in the mouth. Disadvantages of having tube down your nose versus your throat. Smaller airway, that is true. Epistaxis. If you've ever put in a nasogastric tube, you know that sometimes you can cause nosebleeds. This is even more rigid than that. So yes, they could have epistaxis from that. And one of the other things would be sinusitis could develop just from the irritation of the tube at the back of the nose. So those are some advantages and disadvantages of having the tube go via your nose instead of your mouth. Okay, and then I don't know that I have a slide on the next one, but your endotracheal tubes or ET tubes, whether it's going the nose or the mouth, you can't have them more than about 10 to 14 days. So if Carrie is my patient and she's not getting off the ventilator like we thought she could because she's had a stroke or something and things aren't working right, it gets to be day 10, 11. The physician's going to come in and talk to her family about putting in a tracheostomy tube because we don't see her getting off the ventilator in the next couple of days. She's going to need something more long-term. We're going to have to do a tracheostomy. So just keep that in mind, kind of highlight that or circle it. About 10 to 14 days is your window for these types of tubes before we have to revert to a tracheostomy. So endotracheal tubes, the purpose, they provide a patent airway, they relieve respiratory distress, and we said they could be inserted via the nose or the mouth. Indications, oxygen or anesthesia, short-term mechanical ventilation, or deep suctioning. Sometimes we have patients that come in because they have so much mucus and stuff, and that's causing their airway issues, that they'll put in the endotracheal tube and then they're able to deep suction them and be able to get some of that mucus and stuff out. If that doesn't work 100%, they can do bronchoscopies and actually go in and wash and clean mucus out and to help with their oxygenation. So both of them serve this kind of the same purpose, but that is one of the reasons we can use an endotracheal tube. Contraindicated. Well, if you have some type of trauma, edema, or burns to the face or throat, it would be contraindicated. If you have some type of laryngeal spasm or an obstruction, that would limit that we would not be able to do an ET tube or a nasotracheal tube. And then indications for a trach tube: bypass the upper airway, prolonged mechanical ventilation, and it reduces dead space. And then the same would be the others. You could do anesthesia, oxygen, deep suctioning, all of those things. It It wouldn't be short-term ventilation because we already have prolonged there, but the others would be the same. The oxygen, anesthesia, deep suctioning, you could do all of those things through the tracheostomy tube. Advantages and disadvantages of a tracheostomy. Trachs are more comfortable. They have less potential for tube displacement. The patient can eat, drink, swallow with them. They can speak with them. Disadvantages are there is a loss of warming and humidification and filtration because we've lost that upper airway that would normally do that. So they are at a risk for ineffective coughing and an increased risk for infection with them. Care of tracheostomy tubes. The primary goal, obviously, on any type of tube is to maintain a patent airway. So we're going to suction as often as we need to keep the airway patent. Do remember that when we initially put in a tracheostomy tube, the body does view it as a foreign object. And it thinks that if it creates more mucus, the object will go away. In fact, the object does not go away, they just create more mucus. After a few days, 4 or 5 days, the mucus will start to slow down. The body just kind of gives up on that extra mucus production, and it won't be so much copious secretions as what they were having before. But don't be surprised if after the tracheostomy is put in that they do have increased secretions. We clean it every shift. So whether that be every 12 hours, every 8 hours, depending upon your hospital protocol. And you have a skill sheet in your modules for that, and that's what we'll follow for testing. We hydrate to thin secretions as best as possible. We provide humidification of air or oxygen to prevent any type of crusting or drying of secretions. There's actually a tracheostomy mask, and I'll show it to you in lab tomorrow. We want to prevent injury. We want to make sure that we have the correct placement. It should be confirmed by x-ray. It should be in the center of the trachea, approximately 2 centimeters above the carina. When we are suctioning, we avoid jabbing. We rotate the catheter. You can actually vagal stimulate them if you are doing too much jabbing. So we want to make sure we don't do that. We want to prevent infection when we have these. We use a sterile technique when we suction. We use a sterile technique when we care for the stoma, especially if it's brand new. If it's well healed, we'll use a clean technique because that's what the family is utilizing at home. We want to assess a new stoma for any signs and symptoms of infection. We said once it's healed, they can use a clean technique. We change the trach dressing. We do good mouth care. We don't want the dressing around the tracheostomy tube to be moist because it can break down the skin around it. And then they get a full trach tube change, meaning the whole appliance comes out once a month. And oftentimes the first one is going to be done by the surgeon or whoever did it because they're usually still in the hospital. It wouldn't be a month later, but it might be 3 or 4 days down the road, they might come and change the whole appliance out. Okay, letter D. Oh, this is a picture that I've added. These are twill ties. So when you get your kit tomorrow and you open it up, you will actually have about a, 30-inch twill tape, something like that. And normally you would cut it in a 10 and a 20, a third and 2/3 length. And then I'll show you how you would feed it around and tie it. Most places use a nice Velcro tie anymore. The only thing you have to watch on Velcro is that your Velcro doesn't wear out. You probably had Velcro things at home and they get fuzzies and stuff on it, and then they don't want to Velcro very tightly. That's the only disadvantage of the Velcro versus having a square knot. The square knot, it's not going any place with that, but the Velcro could come undone and allow your tracheostomy tube to come displaced.
I'm sorry to interrupt. Can you please repeat the last thing? Did you say the doctor will do it the first time or?
Yeah. They might do it. It depends, actually, what's going on and where they're at when they place it. If they're still in an ICU or something when they place their tracheostomy tube, chances are good the physician probably will change the appliance out. If not, it's not something that RT or nursing can't do. Usually RT would do it in most of your hospitals, but it is something that we could do, but oftentimes the physician will do the first one. And they're just bending over the twill tie, they're making a notch, putting it through the faceplate, and then running this piece through this side of the hole, and that's what holds it. It's kind of pretty slick. It works very well. In your kit, you will have a pre-cut stitched 4x4 with a slit in it. However, it does show you that you can make your own out of a 4x4, just cutting or folding it in thirds. And you can make your own if you don't have a pre-cut. Letter D, trach tube expulsion. What happens? They might have loose ties, poorly tied knot, worn out Velcro. They didn't use two people to change it. So when I say two people, so I've taken this twill tie off, and the trach is just sitting there. Nothing's holding it in place. There's no cuff inflated. There's no nothing, okay? And they go, and this rolls out onto their chest. So that's what we mean about not having two people present. What we would want is either you attach your second twill tie or your Velcro strap before you take it off, or you have somebody don a clean glove and hold the flange in place. Just put two fingers there and hold it while you're doing your twill tie change or your Velcro change, because they'll pop out very easily once this strap is removed. So just be careful about that. Insertion tray at the bedside. We do have, for brand new trachs, we have a tray that you can get up from your distribution center, and it's got some equipment in it that I'll show you here on another slide. Assess their ability to exchange air if their trach tube comes out. Assess if it's partially or completely expelled. Older trachs can be replaced. Just put a new appliance in, use your obturator, take your obturator out, put your inner cannula in, and you've got a new one. It's the brand new ones where we haven't established a good hole yet, that if they come out, they can have laryngeal spasms and the hole can shut off, and it makes it kind of hard to get the new tube back in place. Here's what's in your bedside kit. You have a dilator. You would put that in the stomal hole and spread it apart, or you could have a tracheal hook where you hook the tissue and actually pull it apart. So this would be in your kit on a new trach that you could keep at the bedside for emergencies. Let's see, what else can I tell you on trach tube expulsions? We said evaluate their ability to exchange air. If it's a partial obstruction causing a complete obstruction, don't force it back in. If it'll slip back in pretty easily without much effort, go ahead and do that. If not, cut your twill ties or take your Velcro strap off, and then follow your actions for an expulsion. Like I said, older established trachs, you'll be able to put a new one in with no problem. A fairly new trach, you may have some difficulty, so you might need to call for some help. I mentioned earlier in the lecture that when brand new trachs are put in place, sometimes they don't even use twill ties or Velcro straps. They'll suture it to the neck, and there's no way it's coming out that way. And then after 4 or 5 days, they'll snip the sutures and then use a twill tie or a Velcro strap. And it just keeps the trach from accidentally being expelled with care and stuff. There's no way it can come out when the doctor sutures it right to their neck. So don't be surprised if you see that too. The priority management for the patient is always maintain the airway. So number 1, suction is needed. Okay, and we said it could be quite often. Remember that their oxygen is also humidified. So if they're providing too much humidification, it will cause increased secretions. So if you are suctioning every 20 minutes to a half hour, let RT know. It could be that they're providing too much humidification and need to turn that down also. So just something else to keep in mind. We want to prevent infection, so we said suction using a sterile technique. We've got a skill sheet for that too. We'll follow that. Change the tubings and the solutions per the hospital protocol. Mouth care at least once a shift. You'll be doing it more often than that. You have to use your specific solution from your hospital at least once a shift, but you can use mouth swabs and cleanings, every couple of hours for your patient. And then utilize inline suctioning. And I'll have that for you to look at tomorrow so that you can see what that's all about. You're going to be using an old-fashioned pop-up kit where you pour your saline and stuff. The inline suctioning, everything is all inclusive. All you have to do is just wear clean gloves to manage it. But I'll have one set up so that you can look at that also. Preventing injury. The trachea or the tube should be at the center of the trachea. We said above the point of the bifurcation. You should hear bilateral breath sounds and expansion. This is for an ET tube. It should be at the lip line. So when I show you an ET tube, or you would Google an ET tube, there are hash marks with centimeter markings. So if the physician puts in the ET tube and it's sitting at 21 centimeters at my lips, the next shift or throughout your day, you should be monitoring that 21 centimeters stays at the patient's lips at all times. If it's now at 19, you know that the tube has been shoved in too far, or if it's now at 23, 24, you know the tube has been pulled outward. So we want to make sure that you maintain whatever they say is the correct placement, 20, 21, 22, whatever the centimeter mark is, you need to make sure that the lips stay at that marking at all times. If not, we'll notify RT. RT can come help adjust, and they can also notify the physician if something major has happened. Same precautions as with the trach. Minimize your movement. It can traumatize the larynx. It can contribute to paralysis of the larynx. Discourage mouthing of words. You'd rather have them point at a board. There's usually picture boards that we have that we can give the patient, so if they have to use the bedpan or urinal, and remember, these are coherent patients that are on this, because if they're ventilated and we have them with propofol or some type of medication to sedate them, obviously they're not going to be pointing at a picture board. So these would be awake, alert patients that can help with this. All right, if you have a cuff trach, there are some precautions that we need to do. When do we deflate or inflate the cuff? Cuffs are inflated, remember, to prevent aspiration and seal the trachea for mechanical ventilation. ET tubes pass, they do splint the epiglottis open, therefore they cannot eat or drink when you have an ET tube or a nasotracheal tube. Aspiration can occur. The cuff does kind of help prevent aspiration on a trach tube, but do remember all the precautions in the world. If you have somebody that has a stomach tube, a GI tube, and they're getting feedings through it, remember you got to keep their head of the bed at 30 degrees. You got to turn it off when you put the head of the bed flat, or you're turning them side to side. And if you don't follow some of those protocols, they can still aspirate. Even after you've followed all of the protocols, sometimes aspiration just occurs. When you have a stomach filled with liquid all the time, sometimes it's inevitable that that's going to happen. Trach tubes, remember, are below the epiglottis. Cuffs can be deflated unless we need it to seal the airway. If the patient can manage those secretions, we can deflate the balloon for eating. If not, they may have to have that balloon inflated and their head of the bed elevated for that 30 minutes after they eat. Many patients can have quite a bit of difficulty swallowing when the balloon is inflated, so if at all possible, we do try to deflate it for eating. So if they had mechanical ventilation, it would be inflated. If they have an absent swallowing reflex, it would be inflated. For eating and drinking, it depends. If they're on a mechanical ventilator long term, they're going to have it inflated and the head of the bed up. If they're not on a ventilator but just have a trach and they can manage their secretions, you could deflate the cuff while they eat, and then you could reinflate it after they're done eating. So there's a little bit of gray area. You just kind of have to know your patient and what's going on with them. Number 2, maximum cuff pressures are going to be 25 millimeters of mercury. Complications can occur if it's kept too high. You'll decrease circulation to the area. We can have tracheal ischemia with necrosis that can occur. We can also have tracheoesophageal fistulas when the cuff pressures are too high. Cuff inflation techniques, they are measured by RT every 4 to 8 hours. Cuffs are inflated to the minimal amount possible. Remember, if you have it too high, it causes damage. If you have it too low, they could cough their tube out. So 25 is the max that they would want to utilize. And like I say, RT does manage that. Deflation of the cuff, what happens first, the chicken or the egg? Well, kind of both at the same time. We deflate the cuff and we have them cough and we suction at the same time so that any secretions that were sitting on top of that cuff, when it's deflated, we can suck them up immediately. Okay? So cough and suction all at the same time. Unexplained extubation. It wasn't comfortable for them. They couldn't communicate. They just had it and they pulled their tube out. Nearly 60% of your patients that pull their tubes are oriented. They know exactly what they're doing. 50% will need to be retubed, so make sure you know who your patients are. If I'm taking care of Whitney and she is ventilator dependent, she has to be retubed. We know that. If I'm taking care of Amber and Amber is being weaned and she's doing very well, and probably today at 2 o'clock we're going to wean her completely off. If she pulls her tube out, we're probably not re-intubating her. So you need to know who your ventilator dependent patients are and who are your ones that possibly do not need to be retubed. Prevention is the key. Make sure that you have everything secured. You may need to restrain the patient. You may need to sedate them if you've made every attempt to keep them from pulling that out. 4, make sure you have your equipment handy. Make sure you know where your crash cart is. Make sure RT is aware that you're having difficulty with the patient, because they're the ones that usually brings the bag with all the different sizes of tubes and the blades and the things that the physician wants. Your responsibility would be insert an airway and bag the patient if they accidentally extubate themselves. You just want to maintain an airway until the right people can get there to retube them. Some complications of having different types of tubes. One of the complications is hemorrhage, and this would be postoperatively after they performed a tracheostomy tube. Signs and symptoms are hematoma and swelling, and then those trach ties would be getting tight. So the rule of thumb is that you can get 2 fingers underneath your twill tie or your Velcro strap so you don't cut off their circulation, but you may actually start seeing that tie digging into their neck, and that would give you a good clue that their neck is swelling. They'll have active bleeding. It shouldn't be bright red blood. That should be very minimal. Post-operatively, you should see maybe a serosanguinous drainage for maybe 2 to 3 days. But bright red blood really should not be occurring for our trach patients. Vessel erosion. This isn't a medical emergency. This would be the innominate artery that would be eroding. You see a pulsating tube when you're viewing the trach. You would want to report that immediately. We're going to hyperinflate that cuff. So you're going to shove in as much air as you can to create pressure. You're going to put them on tele, vital signs, and you're going to prepare for emergency surgery. And of course, stay with the patient because they can go downhill very quickly for you. So hyperinflate that cuff. monitor their vital signs, and prepare for emergency surgery. The next one is herniation of the cuff. This is over the end of the lumen. This is caused by overinflation. You'll note it when you go to suction. You might have some type of obstruction, or your ventilator, if they're on a ventilator, might say that there's a high pressure. In other words, it has to push too hard to get the air in, something's blocking it. And again, your high pressure alarm, or you might hear a wheezing sound when you listen with your stethoscope. And our remedy for that is just replace the tube. Letter D, tracheoesophageal fistula. This occurs when there's an opening between the trachea and the esophagus. It can develop from a high cuff pressure. It can develop from you having a nasogastric tube and a trach tube, and they're kind of rubbing against each other, and it causes an open area. So it can happen for a variety of reasons. What happens is we suction food particles, or sometimes your tube feedings will have a blue dye in it, and you have a blue dye that you're suctioning up. Remedy for it, use a small bore feeding tube. One that goes via the nose, or they could have a G tube or a J tube, where you're bypassing that whole esophagus, and then you would just monitor for healing. Because there's really nothing you can do to repair it. It just kind of has to heal up on its own. Letter E, monitor for you. E is tracheomalacia. I talked about that in the first hour, and we talked about the bivona foam cuff. So remember that the posterior wall has no rings. Due to constant pressure, it can progressively dilate. So how do they know it's dilating? Well, RT realizes that it needs more and more pressure to be able to keep the cuff sealed, and then eventually, when they've reached their maximum pressure, there still is not a good seal to the cuff. And what is the remedy for that? It is the bivona foam cuff. Injuries to the larynx. This could be from intubation or just the tube itself. It might have hoarseness or laryngeal nerve damage, and how you would assess that would be dysphagia once the tube is removed. Letter G, aspiration. Head of the bed has to be to 30 to 40 degrees. All your intubated patients, 30 degrees. Okay, 30 degrees is the minimum. Yes, you can lower the head a little bit as long as your tube feedings are off to be able to turn them and reposition them. But as soon as you've done that, the head of the bed comes back at 30 degrees. We check tube feeding residuals every 4 hours. You do not need a physician's order to do that. You probably don't get a very good residual on a small bore feeding tube, but you will on a G tube. J tube, probably not, because it's already going into the jejunum. It continually flows through. But if you have a G tube, yes, you can check a residual. The rule of thumb is usually if your rate is 75, if you get greater than double that, so greater than 150, we would hold it and let the physician know. If your rate is at 100, then our residual would be greater than 200, we would hold it. So rule of thumb is usually double your rate. And remember, aspiration or aspiration pneumonia can occur even if the cuff is properly inflated and your head of the bed is at 30 degrees. It's just a risk we take by having liquid in the belly at all times. This is just a couple pictures here. Here's your tracheoesophageal fistula. You can see the opening between the stomach and the trachea. There's an underinflated cuff. You can see that it would not seal the airway because we don't have enough air in there. Here's a ruptured cuff. They do blow holes in themselves after a while. there are cuff repair kits. I can't say I've ever seen one used, but there are repair kits, or you can just change the whole appliance out. Here's the herniated cuff at the bottom. You can see how it's blocking the airway, so you can see why you would hear wheezing or have a high pressure on the alarm, because as the air is flowing down through, it's meeting a resistance. Hypoxemia. Suctioning can cause oxygen depletion, bring bronchospasms, and atelectasis. We prevent it. We limit our suctioning to 10 to 12 seconds. We suction only when we withdraw the catheter. We keep our suction machine at 80 to 100 millimeters of mercury. We hyperventilate them either with 3 deep breaths of 100% oxygen, or we can sigh them on the ventilator. We wait 3 minutes. I think our skill sheet is wait 2 to 3 minutes after suctioning before you would resuction to let them reoxygenate. And we really don't use normal saline unless they would have a mucus plug or such thick secretions that we can't get it up through the suction catheter. You know, the other day, I don't know, I have a bad habit of this, of swallowing and trying to inhale, I guess at the same time. Either that or I'm getting old. But I keep choking on my liquids or my spit. Either that or I've had a stroke and I don't know it. But I'm telling you, it just about kills me. So can you imagine you take a couple mLs of saline and you squirt it down somebody's tracheal tube or endotracheal tube, and you expect them not to have a conniption on you, especially in those semi-comatose or those fully awake patients. I would come out of that bed and strangle you if you were doing that to me every time you suction me. So only as a last resort, due to a mucus plug or very thick secretions that won't come up through your tube, because it does desat them quite significantly, and it takes a while for that saturation to come back up. So just be careful with that. Some things that tell you that they're not tolerating it very well. Most of your patients, except for your long-term trach patients, will be tellied. So you will be able to see if they have a rate or a rhythm change. Of course, you're able to see what their color changes are like, if they're restless. And I've not had a lot of suction, deep suction patients who have just been like, yeah, come on, I just love having this done. They know it needs to be done, but they do not enjoy it because it makes them cough. It does deplete their oxygen just a little bit. It is not comfortable for them. Confusion, diaphoresis, or maybe a change in their blood pressure you will see. And some of those changes occur if they have a mucus plug. And unfortunately, if they have a mucus plug, you really got to aggressively try to get that out, or their O2 sats will not go up. That's where, in the end, if they have a lot of thick mucus, the physician may do a bronchoscopy and actually go in and wash the area out and suction it to try to get that thick mucus out so they can have a better oxygenation level. So there's limitations to just basic suctioning. Okay, hopefully you got those. And then our last one in this section are cardiac dysrhythmias. So, you know, when you're putting in the suction catheter and you're jabbing, and hopefully you're not, but it can cause premature ventricular contractions. You can have PACs or premature atrials. You could have tachycardia from it. Those are all caused by hypoxemia, and they could lead to a cardiac arrest. Hopefully they don't want to scare you from suctioning your patient, because you're going to have to do that. But we just want to be careful when we do some of these things that we don't cause a lot of extra trauma and stress for them. Bradycardia, we said they could basal stimulation, especially with jabbing. So just use nice, quick, smooth movements for them. And then tachycardia, again, it's often caused by a sympathetic nervous system stimulation with us messing with their respiratory system. All right, very last section of this guide. So when can they be weaned and extubated? They must be able to breathe spontaneously, breathe on their own. They must be able to clear their secretions and maintain their airway. If they can't cough up mucus, there's no sense extubating them because, it's just going to build right back up and they're going to probably go into respiratory arrest. And they have to have stable or satisfactory arterial blood gases when they draw those. And again, those differ between patient to patient, so I don't give you one specific guideline. Here's what your ABG has to say before they can do that, because if they're a COPD patient, it's going to be way different than what a healthy set of lungs would be like. Weaning from a trach. Length of time and the number of steps vary. First thing we're going to do is check them for a fistula. Second thing is we're going to deflate the cuff and use a fenestrated tube for a day or two. Remember, that was the one that let you breathe in and out of your nose and mouth before they actually take that tube. 3, occlude the tube with a button and observe their toleration. We saw one of the pictures with the fenestrated breathing in and out where we had the plug on the end of it. Number 4, eventually the tube can be removed and they steri-strip the area shut. And number 5, we just are observing for toleration. Some patients can have their tube removed and one of those decannulation plugs can be inserted, and then we could reuse the tube if we needed to down the road. Hopefully they wouldn't need to, but sometimes we know our patients don't progress like we want them to, and they take a few steps backward and have to be tubed again. All right. Extubation from the ET tube. It's done by trained personnel only. People that can retube the patient need to be present. They do a high Fowler position. They suction and deflate the cuff. They loosen the tape and instruct the patient to take a deep breath. So on deep inhalation, they will remove the tube. They have them cough and they suction the mouth, and then they get O2 via mask or cannula, usually whatever rate they were on the ventilator with. They try to maintain once they take the tube out. Once they're extubated, you do want to observe for any type of laryngeal spasm. You want to listen for any type of stridor. You want to notify the physician ASAP if that happens. You may need to give them a little epinephrine, or you may need to give them some glucocorticoids to keep them from being reintubated. And you can, I think there's some YouTube videos out there on extubation, so you can actually watch them extubate a patient. They're usually pretty quick, a couple minute videos. And then X is just review oral and nasal airways. There are some independent web resources out there for you. I'll show you nasal trumpets and oral airways in lab tomorrow. You just need to know how to insert them, how long or how big of an oral or a nasal trumpet airway do I need, what are some negative disadvantages or contraindications to using both of those. Okay, so oral airways and nasal airways are different from intubation. These are just something, a block that's put in the mouth to be able to hold the tongue and stuff in place, or in the nose to be able to keep the nasal airway open. So I don't think your skills book from freshman level has those in there unless they've added it, but there are some good resources out on the web that'll show you what they look like and how to get your measurements for your patients. Okay? All right, I'm going to stop sharing this screen. And Now you can switch your papers, and we're going to go to mechanical ventilation. Oops. Do you see that PowerPoint?
No.
Okay. I know what I'm doing here. Let's see. Gotta pull it up. Oh, nuts-a-roni. Oh, Lisa. Nope. I think maybe. Let's see. Oh, shoot. You still don't see it, do you?
Nope.
Okay. All right. Take a 2-second break. I have to log off of this and open it up for it to come back on because it accidentally closed it. So you all stay on the Zoom session and I will rejoin you here in 2 seconds, okay? Oh, I wonder if I end, if you all get logged out. I'm telling you, gosh bless America. Hold on 1 minute.